Bismillahirrahmanirrahim. My topic for today's lecture is stomas. Stomas, ileostomy, stoma, colostomy. Ileostomy is a planned opening made in the colon or small intestine to divert feces and flatus to the abdominal wall, where they can be collected in an external appliance. So, this is our topic today, and this was the definition of stomas. At the end of this lecture, all the students must be able to define stoma. Then they should be able to classify or should know the types of the stomas, how what are the indications of the stomas, and how to manage these stomas. So, if we talk about different classification, intestinal stomas, intestinal stomas, they can be classified into ileostomy or colostomy. Intestinal stoma, another way to is either these stomas can be end or loop. That means it can be an end ileostomy or end colostomy, or loop ileostomy or loop colostomy. There's another way to group these stomas. For example, these intestinal stomas may be temporary or sometimes they are permanent. Principle of stoma formation. So we have to discuss the possibility of a stoma with patients undergoing elective or emergency colorectal surgery. So what is important? That discuss about stoma with the patient who is going to have this procedure on them. Assessment for stomas is another principle of stoma formation, and this is usually done by stoma therapist. Stoma therapists and more different hospitals, they are available. And what is important in this part of the discussion, that all the patient, they are assessed before we form, especially in elective surgery. We discuss with the patient, we probably what is sitting of the stoma. We select the site where we have to form the stoma. So it should be patient is assessed preoperatively while he is lying down in a sitting position, in a standing position. Then we mark this best site for a stoma. An area should be easy to see and access. While selecting these sites, always avoid bony prominence, for example, iliac crest, rib cage, because then it becomes difficult to apply the appliances, stoma appliances. And then we should avoid the area of scars, skin creases, and then anticipated surgical wounds and belt line. So it should not be at the site of the belt line, because we have to, the belt will overlie the this appliance. Stoma creation. Another, when we're discussing the principle of stoma formation, another important aspect is how to create stoma creation. Create an opening about the width of a 2-finger breadth. This is a rough estimate while we making an opening in the interior abdominal wire, that the part of gut which is passing through that hole, it should be minimum about 2-finger breadth. Deliver well vascularized tension-free segment of the bowel through the rectus abdominis. Another important thing, which part of the gut, small intestine or large intestine, is brought out, that should be well vascularized. and while bringing outside that opening, it should be tension free. Otherwise, what will happen? It will become ischemic and will become gangrenous. Before opening, close any other wounds. For example, when we open the gut in stoma formation, before that we close the wound of the laparotomy or any other wound which we have made on the abdominal wall. Then we open the bowel and secure to skin with evenly placed absorbable suture. So we open the gut, then we apply serum full thickness interrupted suture with absorbable suture to the skin around the opening in the abdominal wall. When we make ileostomy, must know something, that ileostomy effluent, whatever comes out of the ileostomy, it is liquid, it is frequently at alkaline pH, it contains activated digestive enzymes discharged almost continuously. So when we make ileostomy, what is important, then we should know what is coming out of it, and it is always discharge is almost continuously from the ileostomy, and this effluent also excoriates these and digests the skin, that causes rash around the ileostomy, and this is important. We should know before making this, so that we can construct ileostomy in a way that these complications should not occur. So to avoid, how we can avoid this excoriation and digestion of the skin, that is in the form that we elevate the ileostomy opening about 2 to 3 centimeters from the skin to ensure the effluent passes, so that the effluent passes directly into a stoma bag with minimal contact with the skin. We can see how this is the skin, and the ileostomy is elevated above the skin about 2 to 3 centimeters. You can see that this is how it is elevated above the skin. Then ileostomy, ileum is everted on itself. This you can see in this photograph, in this diagram, that the ileostomy is everted. The inside is everted outside, and this is here the skin stitches, they are applied to the end of the. So this is the ileum is everted on itself to form a spout. This is spout of the ileostomy, and this is very important because this is going to help to avoid excoriation of the skin. Colostomy. On the other hand, when we talk about the colostomy effluent, the effluent and the contents of the colostomy, which is coming from the colostomy, usually formed stools. They discharge intermittently. It's not continuous outflow of the stool from the colostomy. Because of the movement of the large intestine, usually the discharge is intermittent. It's not continuous, not directly corrosive to the skin. The stool which is coming out from the colostomy, it does not cause corrosion of the skin. It does not digest the skin. So the problem of rash around the colostomy is minimal. It usually falls directly into the stools, they fall directly into the stoma bag, and the problem which occur with the ileostomy, they don't occur with stoma formation, and we don't need any spout in the case of colostomy formation. It can be flushed with the surface, because formed stool, they will come out of this stoma for the colostomy. Colostomies are sutured flush with skin. This is the thing which I was explaining in the previous slide. So the colostomies, as in the case of ileostomy, you have seen, in the case of colostomy, you can see it's not elevated above the skin. It is at the level of the skin, because the contents, they are feces. So they allowed to spout slightly to prevent retraction after weight gain. So that means only slight elevation is required in colostomy as compared to ileostomy, so that if the patient gains weight afterwards, it does not retract. Another way to we have grouped the stoma into temporary stoma or a permanent stoma. So another way we can group them is temporary loop colostomy. Temporary colostomy is usually loop colostomy. That means we bring out a loop of the intestine, whether it's a small intestine or it's a large intestine. Temporary loop colostomy, the idea is to defunction anastomosis after an interior resection. There are a number of indications of temporary transverse loop colostomy. For one example, in this we can see the interior resection, which is colorectal anastomosis lower down. So we can make a loop colostomy which is temporary, and this is going to save the distal anastomosis. Loop left iliac fossa colostomy. That was the previous one, is the transverse colostomy, and another site where we can construct a loop colostomy is in the left iliac fossa, and this is sigmoid loop colostomy. The indication to prevent fecal peritonitis following traumatic injury to the rectum, to facilitate the operative treatment of a high fistula in ano and incontinence. There are cases where incontinence occurs, and in those cases we can do a loop, for example, a traumatic laceration at the level of the anus, anal verge, anal sphincter damage. We can do a loop left iliac fossa colostomy. So these are the indication of temporary loop colostomy. A temporary loop colostomy is made bringing a loop of colon to the surface, where it is held in place by a plastic bridge passed through the mesentery, and that I will explain how that is done. Once the abdomen has been closed, the colostomy is then colostomy. That means the wound of laparotomy is closed first, and then the colon is opened, and the edges of the colonic incision are sutured to the adjacent skin margins. When firm adhesion of the colostomy to the abdominal wall has taken place, that means the fibrinous adhesions, then those fibrinous adhesions, they are formed into fibrous adhesion. So when those are formed, then the bridge can be removed after about 7 days. Bridge which we placed through the mesentery underneath the loop, so that it is not retracted inside. So this is one way of securing the colostomy. This point, distal loopogram, this is basically when for temporary loop colostomy, when we close this loop colostomy, the advantage of this temporary loop colostomy is that we can operate on this patient and revert this colostomy to make it continuous. But before that, we have to do a distal loopogram. This is a contrast study. The distal part of the ball is visualized to check for distal obstruction or containing problem at the site of previous surgeries. So this is very important. A contrast study should be done for the distal part before closing any temporary colostomy. Usually the timing of this colostomy closure is about 2 months afterwards, so that the tissues they become mature. So these are the different areas where the colostomy is formed. This is ascending colostomy. This is transverse colostomy, the place for transverse colostomy. Descending or sigmoid. This is the area of sigmoid. Ascending colon and descending colon colostomies are difficult because these are retroperitoneal. We have to mobilize a lot before bringing them outside with intact blood supply. Transverse colon and sigmoid colon, they have the advantage because they have a lot mobility due to their mesentery. So these areas, they are easy to bring out with their blood supply. Here you can see this is the bridge which we have used a plastic rod beneath the loop through the mesentery. Here you can see that this is an area of transverse loop colostomy in this case. Double barrel colostomy. Double barrel, usually you must imagine a double barrel gun. Here you can see it is rarely used now. One indication of double barrel colostomy was when it's a large gut in a volvulus, sigmoid volvulus, or in that case, this double barrel colostomy was used to be done. So colon is divided so that the both ends can be brought to the surface separately, ensuring that the distal segment is completely defunctioned. This point is very important. In a loop colostomy, it's not 100% diversion. Sometimes what happens, because the posterior wall of the gut is intact, so what happens when there is a peristalsis from the proximal to the distal segment through the posterior wall, which is intact, is propagated. So what happens, there is a synchronized movement, and whatever is coming from the proximal end sometimes is sucked into the distal end. So loop colostomy, if must keep in mind, it's not 100% diversion. So for 100% diversion, what is important, that the ends, they are brought separately to the surface. So they cause complete defunctioning. Here you can see this is double barrel. One end is here and through the same opening. You can see that. It's a double barrel colostomy. Permanent colostomy. Sometimes we have to do a permanent colostomy. That means we are not going to revert it. It is end colostomy. What is the indication? For example, in abdominoplenary resection, what we do, we move the sphincter, anal sphincter even. So in those cases, in carcinoma rectum, lower carcinoma rectum, carcinoma of the anal canal, formed after excision of the rectum for a carcinoma by the abdominoplenary resection. This is one indication of permanent colostomy. Here you can see that distal part, anal canal, rectum, a part of the sigmoid, that is removed in one specimen in abdominoplenary resection, and the proximal end is brought out as end colostomy and permanent colostomy. Here you can see the permanent colostomy has been created. Temporary end colostomy. Sometimes we have to make an end colostomy, but it's temporary. In relation to that, we can explain one procedure, which is Hartmann procedure. You must remember this Hartmann procedure. Sometimes we have to do. This is sometimes done, and when there is a gangrenous sigmoid colon volvulus, or in cases of emergency, the patient, they come with carcinoma rectum with obstruction. So in this patient, what is Hartmann procedure? Basically, that we resect a segment of the colon, sigmoid colon or rectum. In this Hartmann procedure, we cannot bring the distal end of the rectum outside on the surface as mucous fistula. So we close it and put it inside. So the distal end, which is closed and it is inside, and the proximal end is brought out as end colostomy, but it is temporary because we can restore the continuity later on. But remember, Hartmann procedure is very difficult to restore. It's a very difficult because we have to do laparotomy to restore Hartmann procedure. It's a difficult procedure. People usually avoid Hartmann procedure because a lot of effort for restoration is required afterwards, and this is must always done through laparotomy. Ileostomy, it is an artificial opening made, as we explained previously, between the ileum and the skin of the abdominal wall to divert intestinal contents to the exterior without a sphincter to control the timing of its emptying. Effluent is usually liquid, as I explained it previously. The Brooks ileostomy, when we construct ileostomy, we say a spout is made Brooks spout, Brooks ileostomy. Basically, it was adopted because, as I explained in the previous slide, ileostomy is difficult to manage, especially because there are a lot of complications, a lot of excoriation that occurs due to the effluent of the ileostomy on the skin. The surrounding skin is excoriated, it is rashed, and patient have a lot of complaint. So in case of ileostomy, we do a Brooks ileostomy, and it was adapted worldwide after it was introduced in 1952. Brian Brooks, and this basically revolutionized the stoma surgery. Brooks ileostomy, you must remember this name. The spout which we made for ileostomy, which is raised about 2 to 3 centimeter above the skin on the abdominal wall, we call it Brooks ileostomy. And this is a very problems which occur with the ileostomy, they are lessened with when we construct a Brooks ileostomy spout. Sometimes we have to do an end ileostomy. The ileum, the end is brought out, a distal ileum as an end. So this is called permanent end ileostomy. In cases where total proctocolectomy is done, for example in ulcerative colitis, these are the indications: Crohn's disease, familial polyposis coli. These cases we have to do sometime colorectal excision, total proctocolectomy, this is procedure is called. So in those cases we have to bring ileum as ileostomy, which is permanent and ileostomy. Sometimes we can do a temporary end ileostomy, for example after subtotal colectomy with end ileostomy in fulminant or perforated ulcerative colitis, if we have saved the rectum, so that later on we can do a ileorectal anastomosis. Similarly, after a segmental resection of the small bowel where primary anastomosis is unsafe, sometimes it is even in typhoid perforation, in Crohn's disease, in ischemic gut, we have to do an end ileostomy in these cases, and the distal end sometimes we bring out as a mucous fistula. Here you can see this is permanent end ileostomy. The end of the ileum has been brought out as ileostomy. You can see the spout of the ileostomy. It is raised from the skin. It's a temporary end ileostomy, and in this case you can see this is another opening in the left iliac fossa. This is basically mucous fistula. So we bring it outside because when later on we have to revert it, we can easily identify the distal end, which is difficult in cases of Hartmann procedure where the distal end is inside the tummy and the peritoneum, where it becomes difficult to sometimes identify it. Cectostomy is rarely done. That means the opening in the cecum which is brought on the surface is rarely used nowadays. Indication of cectostomy in desperately ill patients with advanced obstruction, closed loop obstruction. This is one indication. Following on-table lavage via the appendectomy, the irrigating catheter can be left in place as a tube cectostomy. We do a appendectomy for we are talking about the peritoneal lavage, the on-table lavage of the colon, when we do, which we do on the table to clean the large gut. So Follies is passed through the opening where we have done the appendicectomy, and through this Foley's catheter, or a tube inside through the appendicular stump at the base of the cecum, and we can wash the whole gut. So cecosmy, a tube, this is called tube cecosmy, and then it is left there for some time and can be removed later on. Short-term measure to allow, the cecosmy is basically a short-term measure to allow a few days for the condition of patient to improve. Reoperation later on for definitive procedure is done in these patients. Stoma appliances. Here you can see different stoma appliances. Protective skin barriers. This is one form of where this is applied. It is sometimes also called wafer. So protects the skin barrier around. This is the part where through which opening colostomy or ileostomy comes out, and there is a surrounding which is attached to the skin, which is basically protects the skin from the effluents. So pouches, they're closed end pouches, drainable pouches. This is closed end. In these cases we have to remove it. Here you can see this is where we can empty the pouch. So this is the part where which is attached to the skin. It's a wafer type part of the stoma bag pouch. So it's a drainable. Here we can empty the pouch, and here we apply a clip which can be removed. Then the bag can be emptied, and again a clip is applied. So stoma appliances, they are available. They are very good appliances, and sometimes they are even smell. They protect from the smell in these appliances. Nowadays, very good appliances they are available. Another aspect of stoma is different complications of stoma. So complication which can occur with stoma, one is ischemia. As I told you, then when we bring the ileum or the colon outside as ileostomy or colostomy, it should be tension free. It should should be well vascularized. So ischemia is one complication. The stoma becomes gangrenous, ischemic. Another complication is retraction. It's not properly mobilized, there is tension on the stoma, then it will retract. Retraction of stoma, another complication. Prolapse of the stoma. I will show some photographs where you can see these complications. Prolapse, the mucosa inside there, it can become, so stoma prolapse is another complication which can occur with stoma formation. Necrosis of the distal end. So stoma can necrose, fistula formation, stenosis of the orifice in the skin. Another complication, very important complication of stoma is parastomal hernia. So hernial sac that is formed in this opening of the skin opening, but it is that sac forms around the part of the gut which comes out as stoma. So parastomal hernia is another complication of stoma formation. Stomas, they can bleed. Lot of bleeding can occur from the stoma due to erosions, and so bleeding is another complication. Colostomy diarrhea is one complication of stoma. We label when there is a diarrhea in this patient, especially colostomy. So we say that patient is having colostomy diarrhea. Dermatitis, changes which occur around stoma. So dermatitis, and psychological complications. Psychological patient who is having stoma, obviously we have to reassure these patients because they are psychologically disturbed. They avoid to go outside, they avoid the different areas. Complication of stoma. Here you can see the ischemia of the gut. This is retracted end of the colostomy. Here you can see stenosis of the end colostomy. This is complication, other complication on the photographs. Say prolapsed end colostomy, parastomal hernia. Here, this is the where you can see the swelling. This is parastomal hernia. Fecal irritant dermatitis. You can see dermatitis all around. This is fecal dermatitis. This is another, as I told you, these are the complications. So thank you for this. So take home message is that what is the colostomy or ileostomy is basically opening, an artificial opening made in the ileum and our colon, which is brought on the surface. I told you, you must know the indications, you must know how this is formed and what are different complications. Then if you have some question, you can ask online. Thank you.